Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with my most friendly and amazing co-host, Dr. J. Calvert. How are you?
I am feeling very friendly, as a matter of fact. How are you doing?
I'm doing okay.
I feel nice, and I'm going to be friendly about your very, very important topic today, because this is a big one that we need to update a bit.
Yes, so today's podcast is going to be about breast reconstruction, which I do a fair amount of. And it is an update. We've done a couple of breast reconstruction podcasts, but they're like way back in the archives and too hard to find. So we're updating a little bit. And for good or for bad, I've been doing a bunch of breast recon recently. And there are some points that seem to come up repeatedly that I just sort of wanted to make sure we go over and really explain.
Yeah, I think, this is something that I don't think patients quite understand it when they're, first of all, breast cancer sucks. Let's start there.
It sucks.
Can we start with that
Yes.
with everybody? It sucks. And because 1 in 8 women have to deal with breast cancer, then you're going to know somebody who's had to go through this. You're going to, God forbid it's something that you have to deal with. But if you do have to deal with it, you got to have the information and have an understanding of what it is you're up against in terms of breast reconstruction, so that you can be powerful in your choices and you can understand the course of treatment.
Yeah, absolutely. And the problem becomes when you have a diagnosis of breast cancer and then you're also seeing consults for breast reconstruction, there's just so much information coming at you and you're already in a vulnerable state and feeling kind of overwhelmed with your diagnosis that it's really hard for what any of your doctors are saying to really sink in. You kind of get bits and pieces from here and from there. And then it's not till after all the surgeries are done that you kind of start asking questions that maybe you didn't hear the answers to the first time, and you're like, wait, what's happening? And so it's a lot. It is a lot. And just to condense this particular podcast, because there are a variety of breast reconstruction options, you could have an entire podcast just about breast reconstruction. Ooh, there's an idea. The spinoff. But for today's purposes, we are talking about breast reconstruction in the face of a patient that has undergone a mastectomy and is having implants for reconstruction. This is not dealing with anybody that's having a lumpectomy or partial mastectomy. It's not dealing for anybody that's having an autologous or tissue-based reconstruction. This is patients who have had a mastectomy or are going to have a mastectomy and are getting reconstruction with implants.
Who was it the other day in the operating room that said autologous? I thought it was funny.
Oh, I don't know.
Oh, I think it was Gabby, our nurse. She read the consent and she said autologous reconstruction.
Autologous.
Autologous rib.
Oh, bless her heart.
It was great.
Autologous. Autologous is the fancy word for it comes from you. It's your own tissue.
I'm voting for autologous.
Autologous.
I think that's going to be the new. And I think Jose said it sounded like a dinosaur. Like, oh man, look at the size of that autologous. It's coming after us. It's an autologous Rex. Anyway, just a little diversion of kind of the things that these words are so difficult, aren't they?
They're so strange.
They're so difficult, and we talk about them when even when I was trying to explain what we do with facelifts. So the terminology, the take-home message here is that the terminology is difficult, and that's why we want to be clear. This is about mastectomy patients getting breast implant reconstruction.
Correct. Mastectomy being removal of the entire breast, not just a part of it in this situation. So there are a couple of reasons patients will get mastectomies. You have patients that are getting them for a cancer diagnosis, and you also have patients that are getting them prophylactically. That means that they have a gene or they have a high risk of getting breast cancer in their future, and so they choose to have mastectomies done before they even have a diagnosis of cancer, just to take it off the table. So those are the two categories or groups of people that will be getting mastectomies. You can have mastectomies on just one breast, or you could have it on both. One is called unilateral, 2 is bilateral. And here is where all my breast surgeons are going to yell at me. I'm going to tell you, if you're going to get one, get them both. And that is not necessarily a golden rule or standard recommendations. In fact, it goes against what a lot of the breast cancer colleges and societies recommend. Your hospital will get dinged if you have too many bilateral mastectomies that aren't indicated for cancer reasons. But I'm telling you, as a woman, as a female, as a plastic surgeon, my most unhappy patients are the ones that only have one side done, and then for the next 20, 30 years, we're trying to make the breasts match and be equal from a reconstruction standpoint. It just can't happen. And I'm going to get into the details of that in a little bit, but that's just my 2 cents. Not to mention, especially if you have any kind of anxiety about your diagnosis, having a diagnosis of breast cancer already and then having to go back every year and get a mammogram on the other side and wait for that news to find out if you may or may not have cancer on that side. And there is some data coming out that show that you may be at a higher risk to get cancer on the other side if you've already had it on the one side. So just to put your mind at ease and to make your reconstruction look so much better, do them both. That's my 2 cents. And it's not, that is a controversial statement. So just putting that out there as my opinion.
That's your opinion, and it's more than 2 cents for sure. I would say that was actually like 27 cents. But the reality is that I agree with you 100%. And it's not. This is not a American Cancer Society recommendation. This is a Dr. Rovelo and Dr. Calvert recommendation that if you want your breast to look the same as best that they can, get bilateral reconstructions, because the truth is you can't match an implant to a breast. If you have a natural-looking breast on one side and then an implant reconstruction,
it's never going to look the same.
It's just not going to get there.
One breast that has no breast tissue, it's just skin. And then you're putting a round, very sort of prosthetic, fake-looking implant underneath it. And then you have another breast, especially if it's on the larger side, that has, it's aged over time. It has some droop to it. Even if you put an implant on that side, even if you do a lift on that other side, which is things we do to try and make them look equal, they are never going to look the same, like not even close, unless you have very small breasts to start out with, in which case you can get away with it. And I'm talking like A-cup breasts. Anything larger than a BB+, they're going to look different. They may look okay in clothes, but naked, in a swimsuit, in a revealing dress, they're going to look like different breasts because one breast has breast tissue and it's going to age and it's going to respond to gravity with breast tissue. And the other one's just going to be like, hey, how's it going? How are you? I'm just here hanging out. I'm never going to drop. I'm never going to sag. I'm just here.
I don't think I've ever heard the implants talk like that. But
well, they
maybe
talk
they
to
do.
me. Oh, they talk to me
You
a
are
lot.
the implant whisperer, so I guess so. Maybe they do. Maybe they do say that.
Just for symmetry purposes, if you have a starting place that's equal for both of them, then you're going to have a much better symmetric result. So that's the bilateral versus unilateral argument. Then there is the topic of whether or not you're preserving the nipples. And whether or not you preserve the nipples is dependent on a couple factors. One of them is whether it's safe from a cancer standpoint, and I always defer that to the breast surgeon. So if the cancer is encroaching on the nipple, getting close to the areola, a lot of times it has to be removed because it's just not safe to leave it behind. But if the cancer is far enough away and they're comfortable not removing it, then you can keep the nipple. You can keep the nipple. Should you keep the nipple from a plastic surgery standpoint is a whole nother story. If you have large breasts and your nipples are at the bottom of the breast or they're looking at the floor, keeping them is not helpful and it's not going to look good. It's hard to say, let's take the nipple when there's nothing wrong with it. But if you're trying to get a really nice reconstruction and you have large breasts and there's a lot of skin, it's not going to look good. It's going to look saggy and the breasts are going to hang really low. And these are patients that I get for revisions and they're like, they're so low and they hang and they don't look cute. I was getting implants. Why don't they look perky? And it's like, because we didn't take any skin. When you don't take the nipple, you don't take any skin. And you have a big skin envelope that you really can't fill up.
Yeah. Do you ever bank the nipple?
No, we do not bank nipples.
I have an absolutely terrible story about a banked nipple that I don't even know if I can tell it on this podcast. It's so awful, but it's real what happened.
I told it. Yeah, you can tell it.
So when we're talking about banking, I'll tell it because it was crazy. And we really never resolved it, and I think you'll get it at the end. So banking the nipple, you take the nipple off at the time of the mastectomy, take it off basically like a thick skin graft.
Yeah.
And we banked it in kind of the groin, like at the top of the thigh for this one patient, where we just made a little incision. She's told her she's going to have a scar there, and we sewed the nipple onto the thigh and bolstered it, and it survived. And then the idea was after we do tissue expansion, this is what happens. You do the mastectomy, you put in a tissue expander, you expand the skin, then you go back and reconstruct with a permanent prosthesis. And then you bring the banked nipple from the thigh up to the breast, and you put it on as a free nipple graft, which was something we do in breast reductions all the time.
Yeah.
Very common. Well, when I was at the University of Pittsburgh at the cancer center there, and we were doing this for a patient, it came time to move the nipple back up, and the patient and the husband said, "We kind of like it on the thigh."
I mean, I could see why. I mean, maybe
I
proximity to other areas.
I don't even want to talk about that. I'm just telling you that we couldn't convince them to move it, and they said, "No, we want you to do a skate flap and make us a nipple," and we were just like, "But you banked the nipple, so don't you think we should put it up on the breast?"
Nope.
And they were like,
"We like it there.
We kind of think it's kind of cool."
So there you have it. We do not do that
Nope,
anymore.
we don't.
That's
no,
not a
there's
thing.
no nipple banking.
No nipple banking.
I've learned my lesson.
But just to go back to nipples, you can keep them or you cannot, and we'll talk about what happens if you don't keep them. But my criteria for keeping the nipples is when I do the reconstruction, can it still look nice? And it still has to, because this is where it's going to get into, gosh, there's so many things there's like so many considerations, and I really feel for patients because this is a whole lecture series. Breast reconstruction is by no means the same as a cosmetic, implant, or lift procedure. And that is so, so, so important to hammer home. I can't tell you, I have patients that come to me after reconstruction and they look beautiful. And then they have in their ear some friend or auntie who's like, "Oh, when I had my breast implants done, they didn't look like that, or I didn't have it." This is not the same deal at all. Like, well, why can't you just do a lift at the same time? Auntie, stop. Like, this is not the same as the cosmetic breast procedure.
No, it's apples and oranges. And that's really important to understand
Super important to understand. Not to say we can't make them look great, because we can. But what you're starting with is totally different. And it all comes down to blood supply. It's all about the blood supply. So in a cosmetic patient, say they have nipples that are starting to descend and their breasts are sitting low and sagging and they want implants. Well, we traditionally do implants with a lift to get the nipple to sit up nice and high directly on top of the implant where it's supposed to be. And we could do that because we have a ton of blood supply going to that nipple. We can cut around it, we can lift it, move it around in space, and it's still getting perfused. When you do a mastectomy, you literally remove every major blood vessel to that nipple. It's only surviving on the little tiny vessels that come through the skin all around it. So now you want to cut around the nipple and move it, it'll literally die. There's no blood supply going to that nipple.
Right.
So at the time of the procedure, it's incredibly difficult to move that nipple from where it is already. So if your nipples are not in a great position to start with, they're not going to be in a great position afterwards, and it's going to affect the result and how it looks. The one caveat is if you don't have an active diagnosis of cancer and you're doing this prophylactically, this is where I love to do a lift ahead of time. I do a lift, I put the nipples exactly where I want them, I reduce the skin envelope so it's not too large. Then in 3-6 months, we go and do the mastectomy. And now I have perfect breasts. And I can do whatever I need to do, and they're going to look beautiful. If you do have an active cancer diagnosis, the other thing I've done is I've done a lift with a lumpectomy. So remove the cancer, get it out of the body, do a lift at the same time. Then come back in 3 to 6 months, do the completion mastectomy and the implants. So there's a lot. There's a lot of steps. There's a lot of different ways of slaying this beast. All to be said, different surgery from a cosmetic, breast implant, and breast lift. And sometimes keeping the nipples is not always the best option. Once you've decided to have whatever surgery you're going to have, as you mentioned, there's options for tissue expanders, which are basically empty implants. So they go in at the time of the mastectomy. They are either flat or they can be filled on the OR table to a certain degree. And then you come back to the office every week, every 2 weeks, and we put more saline into them and slowly expand them to whatever size you want to be, and then go back for a second surgery, which is to swap them out to permanent implants. That's one option for breast implant reconstruction. The second one is instead of putting tissue expanders, you just put in implants right away. So rather than doing the expander phase, you just put in implants, call it a day, sort of. Well, why would you do 2 if you could do 1? Not everyone's a candidate for the single stage. For me personally, and everyone's a little bit different, for me personally, your breast kind of already got to be like, not perfect, but like pretty good. They can't be too big. Nipples have to be more or less in a good position relative to where that implant's going to be. And if they're not any of those things, then I prefer a tissue expander. A tissue expander is also used for patients maybe who are having the nipple removed and they don't have a whole lot of skin left behind. It's really hard to put a larger implant in those patients, so they do well with tissue expansion. There's a couple different reasons why you would do 1 versus 2. But at the end of the day, whether you did it in 1 stage or 2 stage, you're going to have implants for your reconstruction.
They are not breasts.
They are not breasts.
I think, what got us onto this topic was that a lot of our patients who get breast reconstruction are comparing their reconstructions to breast augmentation patients.
Right.
And that's a mistake because they aren't the same. It's just a breast augmentation, there's no cancer. There's no getting all the breast tissue out. There's no
there's still breast tissue left
coverage.
behind.
There's no coverage. These are apples and not even oranges. They're like apples and bowling balls. They're really different.
They're totally. We use the same thing. Both of them have implants, but the procedures are totally different. And for example, in cosmetic breast implants, I typically put implants under the muscle. Typically. The implants or the tissue expanders, I wrap them in some kind of dermal mesh, and then I put them over the muscle. And that is done because, again, going back to cosmetic versus reconstruction, under the muscle in a cosmetic patient, you may see the implant move a little bit when they flex their pectoralis muscles, but it's not a big deal. In a breast reconstruction patient, when they flex their muscles and the implants are under the muscle, you get what's called an animation deformity, and it's really weird looking. Because the skin sticks directly on top of that pectoralis muscle, and so when it flexes, the skin does this weird ripply thing, and it moves with it, and it can be really disconcerting to a lot of patients.
Oh, yeah.
So over the muscle does away with that animation deformity, but you see more of the implant. So the implant is not a firm, rock-hard ball. It's a silicone gel. So it's going to have a few ripples and dimples in it. It's not a solid structure. And you can see some of those dimples under the skin. So you're a little more prone to seeing parts of the implant, which have to be addressed with fat grafting or other little camouflage procedures. So there are some major differences, again, in that regard between reconstruction and cosmetic breast implants. All of that to be said, we can get really good results. And so, we say that patients have these expectations that it's going to be a cosmetic breast augmentation. But we've kind of given them those expectations because we have evolved to a place where we can get really good results. I had a patient today in my office. She was there for her first post-op visit from her surgery. She'd had bilateral nipple-sparing mastectomy, so she kept her nipples, and I put implants in right away. And our scribe, Kim, shout out to Kim, she was there with me. And after we came out, she was like, Dr. Rovelo, did she have a mastectomy? I was like, she did. She was like, I had to double check my nose. She looks exactly the same as she did.
Wow.
I didn't even realize she'd had a mastectomy. I was like, she did 5 days ago. So yes, we can get really good results, but there are limitations to what we get. I think that's the important thing to understand. If you are doing the direct-to-implant route, the implants right away, your breasts are not going to look dramatically different or better than how they started out with. This is not going to be the time that we can change them. We can't make them a whole lot smaller. We can't make them a whole lot bigger. We can't lift the nipples. All going back to blood supply. The breasts you come in with are sort of the breasts you're going to have. Now, if you're going the tissue expander route, I have a lot more leeway to really make these breasts different than how they started.
Right.
So if you really want a different look, more perky, larger, smaller, whatever, tissue expanders are your option. And tissue expanders kind of get a bad rap as like, oh, that's a less evolved way of doing breast reconstruction. I love my tissue expander reconstructions. I mean, they look amazing. And so for, if you just don't love how they look, tissue expanders are a great option. If you're happy with how they look and you're okay with them looking like the same as they do now, then putting implants in right away, it might be an option for you. It's just all about understanding your options and adjusting your expectations.
Yeah, I mean, you got to know where you're starting from too. I mean, like that's like as the patient, when you come in, you have to realize that, it's surgery. It's not a magic wand. And so we can work with what's there. We can work with what you have, where you begin. And there are limitations of where it can go. And I think that's where some of the disconnect and what's possible is for breast reconstruction patients. And the last thing you want to do is, tell somebody like, this is kind of, I know that you're starting with, 29 centimeter, nipple to notch distance, and there's barely any breast tissue there, and I understand you have a cancer, and when this is over, you're going to look like you are bikini ready, and like, let's get you in for a photo shoot.
No,
That's not what happens. That's not what happens. The fact that your breasts are what they are is where you start, and so the discussion with your reconstructive surgeon is really important. It's really, really important to manage expectations, because maybe implants aren't the right reconstruction for you. Maybe you do need an autologous reconstruction, an autologous rex. And then you're talking about doing some sort of DIEP flap where you're taking the belly skin or even my classic favorite, a latissimus dorsi muscle and skin flap that does, incredible reconstruction and gives you lots of coverage and incredible soft tissue. And so there are other options. And so having that discussion of what's possible really is the beginning point to having a satisfying reconstructive experience, knowing that it's a project, that this is a project. It is not a one and done.
It isn't. Even when we say it's one and done, we're going to put implants in, high five on your way. There's probably going to be a revision or two in the future.
Definitely.
It's not one and done. I think that's kind of the last point I want to make here is that this is definitely a process. It's definitely a journey. And the recovery and the surgery itself is hard. This is not, like you said, this is not magic wand surgery. There's a lot that goes in to creating a breast out of nothing. Like when that mastectomy surgeon is done, it is a giant wide open space. There's no breast pocket. There's no breast borders. It's obliterated. It's gone. The fold usually isn't there. The lateral border on the outside is gone. Like it is just a blank slate. And so going in and putting in an implant right away and creating what looks like a natural breast it's hard. There's a lot of moving parts to it. And I have so many people that are like shocked by the fact they're like, oh gosh, your part took longer than the breast surgeons did. I hear that all the time. I'm like, not a magic wand, people. Not a magic wand. What I'm going to do to make this a breast is going to take a lot of time, and it's going to be really hard work. And they have a strong chance of coming out looking really great. But it takes a lot of time. And that's just in the OR. Then you have the whole recovery process, which now the hard part's on the patient, because sticking through that recovery, you're going to have drains. I keep them in for 2 to 3 weeks because I don't want fluid reaccumulating. You're not going to be able to leave the house except to go to your doctor's appointments. You have to be really paranoid about infections. You have to take it really easy. Like there's a lot on the patient in the postoperative period to maintain a great result going forward. And it can definitely be a lot. And it's obviously way more than a cosmetic reconstruction or surgery. So knowing upfront that this is going to be a big deal surgery, the plastic surgery is not the cherry on top. It's not the icing on the procedure. It is the bulk of your procedure. And it's a big deal. And the recovery is a big deal. And you're going to get through it. And chances are you're going to do great. But you just got to have a good understanding. So when you come to your consult, when you come to your pre-op, bring a person with you, bring a friend, bring someone that can be a separate eyes and ears for you, because a lot of times this isn't going to necessarily sink in. Or
Yeah,
listen to this podcast.
yeah. I mean, well, it's good to have a sounding board, and certainly there are plenty of breast cancer support groups that are usually run through the local hospitals, and so I think that's also helpful just to hear other people talk about it and
For sure.
and to be dialed in. I mean, these things that we come up against as humans, they're really it's just such a challenge, and it rips at the heart of who we are. Like if you're having your breast removed, this is like it's like
It's
it's life altering. It's
it is
so
huge.
big deal, and it's just it's not something you want to just kind of say, well, I'll just get through it. No, you want to be want to be prepared. You want to be a fighter for yourself and get the information you need and get your doc and your plastic surgeon on board and family members, whoever you can. But be aware that we get it.
Oh, no, 1,000% we get it. And talking to other people who've been through it is certainly helpful. The one thing I will say is beware of some of like the Facebook groups for breast cancer, breast reconstruction. Those have caused me so much grief and my poor patients so much grief.
I mean, the
Because
misinformation is deep. It
and
is
it's
a
like,
subterfuge of idiocy.
and it's not even that. It's just like, well, there is some of that. But
There's a lot of that.
I mean, as we've, alluded to a couple of times here, like this is a comprehensive area, and there are so many variables between individual patients' diagnoses, the individual patient's breast, individual treatment options, like what their breasts look like, what they're hoping to achieve, what their surgeons are comfortable doing. I mean, you can't even compare breast reconstruction among other breast cancer patients because it's such an individualized approach. So if you're like, oh, well, but this person on the Facebook group received this kind of reconstruction, like why didn't I have that? Or why didn't like there's plenty of reasons why maybe that didn't happen for you or why your results are different from someone else's. So certainly talking to other people is very helpful, but grain of salt, really no two breast reconstructions are alike.
100%. I think that is really the take-home message.
And I think that's it. So, yeah, if you have questions, certainly feel free to reach out and listen to the podcast. I love doing breast reconstruction. We do it all the time. So, I hope that was helpful. And
Very helpful.
this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.